Welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults through our content that informs, community that inspires, and courses that deliver.
Hello, and welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults. I'm your host, Nicole, and this is the State of the SNF. In today's episode, we're going to discuss what medical reconciliation looks like in the highly medical controlled environment and the highly segmented environment that is the SNF. Let's get going. I know in this podcast we've talked about medical reconciliation before in the context of home health and what it looks like when you are in someone's home looking at their medication lists after they've been in a facility. What I want to look at today is what does this look like when you are in a facility where you as the PT don't really have control of that, where it's actively being handled by other people. What is our role to play and where can we really shine in this? I want to quote the APTA itself on this. And the statement says, "The APTA believes, and it has been acknowledged in federal guidance, that it is within the scope of the physical therapist to perform a patient screen in which medication issues are assessed, even if the physical therapist does not perform the specific care needed to address the medication issue. The physical therapist is competent and qualified to serve as case manager and facilitate coordination of care with physicians and nurses." Now, I pulled this from the article I linked on the Ethics in Practice from October of 2018, PT Now, Hard to Reconcile. And I wanted to look at the idea of the physical therapist as case manager, right? Because in the SNF, we have active case managers. Same as any other setting, there are active case managers. But we are arguably the people who spend the most time with these patients, right? We are seeing their behavior day to day, we are seeing their physical function day to day over an extended period. And if we're doing our job right, we are speaking with the nurses, the CNAs, the OTs, the speech therapists, and we're trying to put all of this together in a picture of what is the patient actually capable of, what are they doing? So we could take a step back and look at ourselves as a case manager, functioning as a case manager, because we are putting all these pieces together and looking at the oversight. Can we all agree to that? Right. And then I want to look at the place where it says we facilitate the coordination of care with physicians and nurses. And I had a conversation, I want to say last week, with somebody actually outside the PT field, but also in the medical field. And we were talking about productivity standards and how it puts pressure on us to focus on our distinct places of patient care and our distinct fields, when in fact, what we also need to be looking at is the interdisciplinary aspect of it, of making sure that we're coordinating care with all the others on the medical team. And if you remember, one of my first podcasts was about how, the phrase jokingly, teamwork makes the dream work, and how we all work together in the SNF, and that's where you're going to get your best result. Not if you're like, well, I'm a PT and this is what I do, and you're a nurse and that's what you do, and seeing that as two separate things. When you see yourselves as parts of a coordinating team, that is what is going to really lead to your good outcomes. All right, so what does all this look like in the highly segmented setup of a SNF, where I have my defined role, and OT has their defined role, and nursing has their defined role, and speech has their defined role? What is our responsibility as a physical therapist to our patients in understanding their medication in a very medically controlled environment? What I'm looking at is we need to understand the impacts of medications on things like level of alertness, cognition, delirium is a big one, their ability to focus, the effects on exercise. I know one of the things that we talked about before, and another one is beta blockers and heart rate, right? If you have a patient who is on beta blockers, you're going to see a blunting of their heart response to activity. So what are you looking at there? If we're doing our vitals, you may not see a big thing, but are you asking about their perceived exertion? Or are you talking about a Borg scale with them? Because these are the people where maybe their vitals aren't changing significantly, but are you hearing a change in their breathing pattern? Are you noticing that they're having trouble continuing? These are all the places where you need to be aware that what you're seeing as the vitals may not be the be-all, end-all of that patient's experience, correct? Another common issue I see in my facility is heparin. So when our patients are non-ambulatory, a lot of times they will be on heparin. And then once we get them walking consistently, in my facility, it's about 150 feet daily. We can speak with the nurses, and a lot of times the nurses will approach us to ask, are they walking? Can we get them off the heparin? So that's also something to be aware of, like how what you're doing to the patient can actually impact the medications that they're on. Because you'll see things like heparin short-term, Coumadin more long-term. So that's something else to be aware of. The facility I work in also has a heart failure designation, so I see a lot of patients on Lasix. I see patients who come in not on Lasix and end up starting on Lasix because they are now holding fluid. I see people who come in on one dose of Lasix and then the dose gets changed on their progress. Are they still holding fluid? Is it making a difference? And now we have to start thinking about, what does their bathroom use in session look like? Am I going to have to be aware that they're going to have to go more frequently, and do I work that into my treatment? Yes, the answer is you try to work that into your treatment. Are we now looking at, with an increased dose, are we looking at changing fluids? Are they monitoring fluids? Are we increasing fluids? Like, what does that look like from the nursing perspective? What do they want you to do in session to help assist with that? But I think one of the places where we can really shine is in discharge planning, because we are having more in-depth conversations with the patients. We are taking that time to sit there. If you're with someone for 60 minutes, most cases you're going to be talking to them, right? So we can talk about what home looks like. We can talk about what they were doing prior. We can talk about what supplements they were taking prior to coming in. I think we can all agree that supplements are not going away, and in fact that they are increasing in use. So what does that look like in a patient who has a new medication? Right? For example, St. John's wort. I really don't understand why anyone takes St. John's wort if they still do, because it's been shown to do mostly nothing for depression, which is what people were using it for. And it interacts with immunosuppressants, antiretrovirals, oral contraceptives, Coumadin, digoxin, benzodiazepines, selective serotonin reuptake inhibitors, which you don't want that interaction happening if you're trying to help depression, monoamine oxidase inhibitors, so MAOIs. So that's a pretty good chunk of medications that St. John's wort is interacting with. So you want to know if your patient is still thinking that's a good idea and kind of try to squish that. Golden seal, which is actually something I had never heard of, has been promoted for skin infections, cold, flu, and diarrhea. It's actually an inhibitor of liver and intestine enzymes and has high potential for interaction with medications. So that's something you want to look at. Evening primrose oil and anti-seizure meds is also something that was flagged. They're not quite sure how that's working yet. So if your patient is saying that they're taking these supplements, you want to maybe try to pull up some information and be like, maybe you should talk to your pharmacist about this. Maybe you should talk to the doctor about this. And just put that idea in their head that they could be increasing their potential for side effects or decreasing the efficacy of their medications. Because just because something is natural doesn't always make it better. And now we were talking about blood thinners. So anyone who's newly on warfarin, also known as Coumadin, that will cause a change in their supplement intake also, because warfarin has a significant list of things that it interacts with. And you want people to be aware of that as well. So, like I said, I really think that when we discuss medications with our patients, when we discuss discharge, we have the chance to really bring in all of these other things because we can take the time to have these conversations. The other thing is, in the SNF, you're seeing a lot of people with some polypharmacy issues, which may be new to them. They may not have been on these medications at home. They may feel uncomfortable about it, and they may not understand how these things are working. And sometimes you get people who are very quick to want to be like, I want to be off this drug, I want to be off this drug. But if you can explain to them why they're on it, what the outcome is expected to be, and why they need to be taking it to manage their new issue. Because a lot of times I'll get someone who says, well, I wasn't on this before I went to the hospital. And I'm usually like, well, you didn't have whatever condition that you knew about or you were dealing with before you went to the hospital. It's not the hospital that gave you this medication. It's the condition that you were not dealing with that sent you to the hospital that now we're addressing. So polypharmacy, while it's an issue for us to see how things interact and how that affects the way the patients are able to perform in therapy, it can also be an issue for some of the patients who tend to be more supplement-minded or more wellness-minded, and all of a sudden are like, I wasn't doing this before, now I have to do this. What's another good thing to talk about with the patients is the fact of medical non-adherence. Maybe you have a patient who wasn't taking their medications, and now that has directly led to them being in the hospital and being in the SNF with you. And you can talk about why they're not taking their medications. Is it because they don't want to? They don't feel like they need them? Is it an access issue? Because you can address all those things differently. You can address a non-access issue with, coordinating with your social worker and be like, this is an issue that we're having. This is why. Do they not think they need the medication? Are they forgetting to take the medication? So, like I said, even though we are in the SNF, in a bubble where everyone around us is doing the work of very specific and very segmented jobs, we have the ability to look at the whole picture of the patient, just like you would do in home care, just like you would do in outpatient. Our patients still deserve for us to look at them as a whole person and address everything that's going on. And if we're not understanding their medications, we're not looking at them as a whole person, and we're not fully understanding what's going on. So when you're doing your chart reviews, I want you to take the time to look at that med list, even though someone else has already read it, even though the nurses are monitoring. It's not enough that the nurses know. You look at that list, see what that patient is taking, and make sure you understand what that is treating, what some side effects could be, and how that's going to impact the picture of your patient as a whole person. And I think that is how we do medicine reconciliation in the SNF. Realizing we're part of a team, but realizing that we still need to see that whole patient perspective that we have been advocating for in our profession, the whole wellness-facing option, everything that the APTA has been working for. We still need to see that. So in the show notes, I've included a link to the APTA PT Now column that I cited, and I also included a link to the American Geriatric Society 2019 updated AGS Beers criteria for potentially inappropriate medication use in older adults. Again, not that we can always change what medications they're on, but we can be aware of medications that are maybe not highly recommended for that age population and why. And then we can know what to look for interactions or for side effects Or even we can say in a, multidisciplinary meeting, I'm seeing this and I'm concerned about it. Don't be intimidated by the fact that you are not a nurse or you are not a physician. There is a place for you to have that conversation if you are respectful about it and realize that you can still have some impact, right? We are qualified to serve as a case manager and facilitate coordination of care with physicians and nurses. Advocate for your patient, understand the whole patient picture, serve as that case manager, and facilitate coordination of care. Thank you all so much for listening. I hope that you find something in here that was useful, and I'll talk to you soon.
Thank you for listening to the Jaros Health Podcast. Go to jaroshealth.com to get the show notes for this episode and find out how you can join the Jaros community for free. You'll get access to our private Facebook group and the weekly Jaros Recap, where we share our favorite reads, podcasts, and any interesting conversations in the Jaros community that week. Once again, that's GEROS health.com. Thanks for listening.